to close out, we have Daniel Kraft. He is a Stanford and Harvard trained physician, scientist, inventor, entrepreneur, and innovator with over 25 years of experience in clinical practice and biomedical and healthcare research and innovation. And he's the founder and chair of Exponential Medicine. So Daniel, I will kick this off to you. Thanks.
Okay. Thanks. It's good to be here virtually. Hope all the technology is working. As Ricky mentioned, I'm sort of a traditional physician scientist type, but have particularly over the last decade or so sort of been at this convergence of where technology can take healthcare, and certainly the conversations from earlier today and in the zeitgeist of where data is now and where it's moving are certainly ripe to reshape healthcare. I'll see if I can share my slides here. Essentially, I think we've got 30 minutes for me to kind of hopefully run through some more higher level elements. I'm not going to go into the weeds and fire and APIs, but hopefully some things that can frame where we can go with some of these new capabilities moving forward in the near term, medium, and longer. So that's a bit of the framing. A lot of that, of course, is riding a lot of the technologies that are now becoming quite magical and have reshaped many fields. Quote unquote disruption is sort of overused word, but we've seen it change how we do our banking and how we get our entertainment. You've heard about the fourth industrial age. Healthcare arguably is still a bit in the third, sometimes even the second industrial age. And I think the conversations and many of the folks who've already been participating in this conference are helping shift us into that fourth age. It makes us potentially reshape and rethink all elements of care. The future of a hospital. What is that going to look like? We just opened up a brand new one down the street at Stanford, where I trained. I helped lead a conference on the future of the hospital a year ago in Israel with CEOs of Stanford and Hopkins and others. And our sort of takeaway was that the future of the hospital is no longer going to be the hospital. Will increasingly be in this virtualized, hopefully very data-driven age where care happens sort of anywhere, anytime. But we still have to start with where we are today, right? With many of our interoperable challenges, data silos, et cetera. If I go back 20 years when I was a resident at Mass General, if I go back and even visit the ward at MGH where I trained, it hasn't really physically looked much different from 20 years ago. Same alarms are beeping, some of the same nurses, some of the same patients. The only difference is the young intern on call is now pushing around a laptop and typing the medical record and putting it in a shadow paper chart. We used to handwrite them, and we're still using fax machines to communicate to the pharmacy down the street. So we're still in the fax machine era. We're still using clipboards in most clinical settings. I love this tweet from a year or so ago. Some people say that AI will replace doctors, but I can't really hear them over the sound of my pager beeping, heavy-handed paper printing on carbon copy triplicate of order sheets and tab F12 or keying. So that's still the reality for many clinicians in the trenches, and we need to shift that forward, moving forward. We're still, of course, in the era of waiting rooms, siloed care, often defined by old academic models or simply by anatomy, when we're learning that many diseases now are best understood at the genomic level. And so we have a real opportunity, particularly in this age of exponential, connected, data-driven care to really get out of our silos and reimagine the whole healthcare paradigm. So part of that is a bit of a mindset-driven and societally driven, sick care versus healthcare. The sick care model is really how most of us still operate, intermittent episodic data. Each of us hopefully are relatively healthy, or even if we're not, we're still in the clinical environment 0.0001% of our time. So you get your average annual labs, maybe EKG. Even if you are a patient with hypertension or diabetes, how easy is it for you to get your glucometer data or blood pressure cuff data through to your clinician? They even look at that data, even if you scribble it down and fax it or PDF or email it to them. So intermittent episodic data is how we're practicing still today in 2020. That leads to our reactive model, waiting for the patient to show up with heart attack, with stroke. I'm an oncologist. Most patients show up, present with late stage disease. So big picture, as we connect these data pipes, as we crowdsource information, as we have it become more real time, we'll hopefully become much more continuous with our information that now can be collected, as we'll talk about more, in almost any regard, from our wearables and smart homes and ambient environment. Be much more personalized and proactive with that data, the 4 Ps, started off by Lee Hood. And then that can start to happen much more anytime, anywhere, arguably at lower cost, and can democratize and improve equity and information and knowledge going downstream. So that's a bit of the framework. Of course, we can move the needle towards better treatment and prevention disease. There's also this idea now that we can think about leveraging new data forms to optimize precision wellness, and then hopefully impact our overall health span, not just lifespan, because no one wants to be 120 and feel 120. So I'm going to try and go through a quick arc in these 25 minutes left. Crossing where does data and some of the pieces that talked about earlier today play into health, wellness, prevention, using new forms of information, how we leverage that into better, smarter diagnostics, more tuned, precise, personalized therapy, and a bit about how do we, again, connect the dots to leverage better, faster discovery, not waiting 17 years or 10 years for a clinical trial to happen and fail. So lots of opportunity across the healthcare continuum. A lot of, I think, the future of medicine is in the zeitgeist right now. I was lucky to write the opening article for the National Geographic Future of Medicine article last year. And they kind of retitled it on me, 12 innovations that will revolutionize the future of medicine. Analytics enabled individualized attention will not just treat disease, but prevent it. So while it's easy to highlight individual innovations, I think it's more interesting when we really start to put them together to create whole new forms of information, action, therapy, and start to really match that to the individual. And of course, a lot of these technologies are riding exponential trends. The fact that we're all mostly working from home and connected by Zoom or YouTube is riding the power of exponentials, Moore's law, everyone's familiar with. I like to carry around my favorite antique. It's an iPhone 2 from 10 years ago. 10 years ago, this felt quite amazing. Now when I charge it up, it feels kind of slow and clunky. It still works. And soon in 10 years, my iPhone 11 will look antique. So how do you, as you're thinking about creating new clinical endeavors, new data structures, how do you not just think about the 2020 realm, but where will Moore's law be in a couple more clicks? How might we think about, as Moore's law peters out, where quantum computing is going to take us? How do we kind of, reimagine healthcare still kind of on the left here, siloed, sometimes analog devices, shift that to this era of, democratized, digitized, demonetized technologies that really, not that there's an app for everything or we can make everything seamless and mobile, but really kind of change the game as we've seen across many other fields. So that's a bit of framing. And our challenge for all of us is to get a little bit on an exponential curve to make things happen now, but also architect things so that there's room for these things to work in the next years. So part of the elements here of new technologies is it's enabling all of us as consumers to have access to not just data, but hopefully information to compare one hospital down the street to another, Yelps for doctors like vitals.com, GoodRx, which I used the other day to find the best price for a prescription at the right pharmacy, surgical scorecard, new data and insights on how individual surgeons might be doing in an individual, in this case, let's say knee replacement. Are you going to want to go see the guy on the right with a high adjusted rate of complications or the surgeon on the left? So new sort of forms of transparency, which many clinicians, by the way, don't want to reveal. Clinicians, hospital systems, how are they doing? Because someone is going to be below average. 50% of doctors are below average. So how do we sort of take the data, mortality by surgeon, help optimize them when you see that they're falling off the curve and raise the game for everybody? So we have lots of new tools. Obviously, the smartphone is becoming medicalized in all sorts of interesting ways and creating new data sources and new ways we can do things. My favorite example from last year was simply modifying the microphone and the speaker and a little piece of paper to look in your kid's ear and do they have an effusion, and maybe potentially to tell you is it bacterial or viral. And as a pediatrician myself, that would be certainly useful, or as a parent as I am as well, not to have to drag your kid to the clinic. The problem is the pediatrician, is the healthcare system going to want to use that type of technology if it is misaligned with the incentives, which are clearly rife across healthcare? If you can't bill for doing that e-visit, or who charges and who validates and regulates that software as a medical device as well. So things are moving from our, what fit on our desktop now fits on our smartwatch. Those are becoming clearly FDA cleared for certain indications. Those are going to expand dramatically, well beyond just sorting your movement and your EKG. It's clearly creating this internet of things, internet of medical things, internet of the body, internet of healthcare, whatever your favorite IoT word would be. But of course, and part of the the elements discussed today and some of these new rules about data sharing will hopefully now connect the dots between what we can do from our Fitbits all the way to the intensive care unit and help that data come together and be made sense of. 5G, of course, is becoming a little still hyped, but potentially the new norm relatively soon. Maybe you can reinvent how we're doing interventions. Surgeons in China have already shown they can do 5G mediated surgery. So you're home in your pajamas and with low latency networks, there's a lot more we can do. Now, of course, and it's already been brought up, I think, many times today, is all these new data sources are great, but they're often still siloed. There's all the issues of data blocking. Of course, the new rules out the other day, which I got a taste of today in the conversation, will hopefully enable connecting of these dots. But we have massive amounts of data, and that's still a bit of a so what? Maybe from that data we're going to create new knowledge. But this is my favorite graph. Some of you may have seen, made by Michael Liebman a few years ago. Is great, all this new data, but there's still a big amount of work to turn that actually into truly not overwhelming information, and then to narrow that gap between information to knowledge that can be used at the point of care, clinical utility for the consumer, the patient, the clinician, the hospital, so that when something's published, or you might hear about it in a conference, it's automatically integrated into the workflow of the clinician to use that just in time. And so I think that narrowing of the gap is critical. We still have a lot of amazing innovations here today that aren't used, new data forms that aren't utilized. Something as simple as pharmacogenomics for picking a statin could be utilized, not yet narrowed in terms of that gap. And of course, it's not about the technology, the data itself, it's understanding the incentives, which can be quite different in many healthcare systems in the United States, let alone around the world. Our incentives clearly are still mostly on the sick care side, paying for disease management rather than sort of health and prevention. There's the ancient Chinese way of doing it, where the doctor in the Chinese village only got paid when the villagers were healthy. So we're starting to, of course, to move to the outcomes being the new incomes, value-based care, which creates new opportunities to take some of these new data streams, ownership models, sharing, and align incentives, as has been discussed earlier. About what we incentivize, including how we use our information. 20 years ago or so, pain was sort of buzzworded up and labeled as the fifth vital sign. And hospitals, doctors, nurses, ERs were measuring on how well they control pain, and that contributed to overprescription of opiates and the rise of the opioid epidemic. So just one of many examples. Or the new rules around not paying for hospital readmissions in 30 days have actually maybe led to higher morbidity mortality, maybe less admissions, but the overall death rates may have gone potentially even up. So careful. So new incentives and new ways of collecting and sharing data and information change where healthcare happens, from the hospital to the home to the phone to on and inside our bodies to the corner pharmacy. Clearly what you can do, what you can collect in terms of data information, what can be done with an upskilled pharmacist or nurse practitioner is changing the game. What can of course be done now through our telehealth platforms, all the way to big new systems coming together. Walmart Health rolled out their first 2 Walmart Health centers in Georgia. Will be quite disruptive, I think, and will hopefully bring better access and new forms of care. So all of this, of course, now is this new data forms, new ways to put them together, new ways to mash them up, connected health, mobile health, digital health, whatever we want to call it. It does give us this new form of leveraging data sources, hopefully individualizing the precision digital health, and creating apps and services that again match the individual location, age, culture, language, etc. And of course, it's not a panacea. Just giving someone an app to quit smoking or manage their meds, or a Fitbit, is not going to mean you're going to change, lose weight, or improve adherence. There's several groups now, of course, studying this realm and new forms of collaboration so we can do sort of digitally enabled trials. So of course, it's not about digital only and data. It's all these elements that are converging: robotics, synthetic biology, low-cost genomics, virtual reality, telehealth. It's creating entire new fields. I mean, when I was a medical student, we had technology and healthcare, and most of the fields that are in that middle column there, from computational biology to digiceuticals to robotic surgery, didn't even exist. So it's a whole new interesting time to kind of put these things together to address the challenges we have in healthcare that everyone's quite familiar with, from rising costs, demographics, lack of access, to how do we manage all this data and turn it into actionable information and not have to fax the information around or repeat scans and drive it around on CD-ROMs, including how do we help the regulators, whether it's how we're changing the rules and how data must be shared, to how we help the FDA regulate apps and AI, and how do we regulate, or how do we help the payers incentivize by paying for that new data stream or app or digital or connected platform. Of course, it's not just about in terms of impact medical elements. Social determinants, of course, are becoming more and more recognized, and understanding that our zip code is more important than our genetic code. So paying attention to vaccinations, clean water, of course, in our COVID era, washing your hands, and access to care. We have some new particularly data-driven needs, from accessing Wi-Fi to, of course, battery life. So ways to think about our core Maslow's hierarchy going forward. So I think we all know we're in the realm of disruption and change. Uber's overused example, the Uber of this, Uber of that. Uber, of course, and Lyft have gone into healthcare. Press a button, get a nurse to give you your flu vaccine, or get folks to clinic. Doctor calls, drug delivery, all that sort of elements of connecting the dots to sort of reinvent and get rid of some of the kludgy friction that we see across many healthcare elements. Amazon Care, we'll see it just rolled out for Amazon employees last month. It'll be interesting to see where that goes. And they've got the real ability to get rid of the middleman and reduce costs. Obviously getting to the pharmacy space. And I think 10 years, many of us may have Amazon Health Prime and have our drugs delivered by drone. Drones are another area that are moving quickly, FAA approved, all the way to drone ambulances. I think we'll see here in the next decade moving forward. Back onto the disruptive realm, even Facebook, which has had some challenges with privacy and data, is getting into the space, at least starting to provide some simple nudges to folks about preventative health, and has tremendous opportunity, just like on the I'm safe button, to potentially be leveraged into our era of pandemics, all the way to other sort of social and public health and personal health emergencies and conditions. So things are changing for pharma, it's changing for our payers, all these other examples of technologies that have been changed and disrupted and gone away. Blockbuster, RIM, BlackBerry, Kodak went bust because they didn't pay attention to the rise of digital photography. So we want to be the disruptor, not the disruptee, within reason. And the sort of fun takeaway is we can Uber ourselves before we get Kodak. So fun way to think about it. Of course, sometimes you'll see a technology, it's like, this isn't really ready for prime time. We underestimate, particularly on the exponentials, how quickly those can improve. I saw an example of this. This is in the Dubai airport in November. This autonomous following suitcase. It looked a little bit drunk, actually. It wasn't really following the guy. We kept bumping into things. I thought it was interesting, but it kind of kept going. So a couple more improvements, a couple more iterations, we all may be followed by our suitcases or things following in drones. So don't underestimate what things will go. I've had a fun lens of looking at this as the chair of medicine at Singularity University since it started 10, 11 years ago. Part of what we do there is understand where these technologies can come together to, in my case, impact healthcare. Started a program called Exponential Medicine 9 years ago. We've grown that to about 800 folks every year at the Hotel Del Coronado. And what's interesting, particularly about exponential medicine, is that, and sort of the lessons are, if you're a data geek or a health IT person, you need to be playing with, the physicians, nurses, patients, to understand where some of the needs are, where some of the technologies are going, mixing up, as was mentioned, lessons from other countries, their healthcare IT systems. What can we learn as we kind of collaborate and learn from others, rather than having to reinvent the wheel? And how do we change our mindsets? Tony Young, the head of NHS Innovation, has been on our faculty several times. This is an old quote. The difficulty lies not in the new ideas, but in escaping from the old ones. And a lot of our systems and even leaders are still stuck in the old ways of doing things. So it means we need to bring in the regulators, like Bakul Patel, who we brought in. We helped show them, the FDA, what's coming, and that helped firm up what they've been doing in terms of software as a medical device and pre-check. So bring the regulators along, as many folks there have been doing. So hopefully some of you can join us this November for the next version, and tons of great videos and talks from folks like John Halamka at exponentialmedicine.com. Okay, quickly now, health and prevention. How do we take these new data modes and make sense of them going forward? Genetics are important, but our behaviors are now becoming digitized. Fitbit only launched just over 10 years ago, and now we have the ability to sort of digitally look at the behavior of almost anybody. I'm wearing different versions of Fitbits. I sometimes like to compare the data, but I often ask when I give live talks, how many physicians out there? I did grand rounds at a Kaiser about a month ago. What was striking to me, it was Kaiser, almost any other clinical group, they're not leveraging wearables in any real way today yet, or other forms of personalized data. When I went rounding with the Kaiser team, it was like rounding 30 years ago. Not much had changed in terms of running your med list and your patients. But the question is, now that we can sort of measure almost every element of physiology and behavior, how do we start to integrate that into the clinical care? It could be small data, just like how many steps you're taking. If you're just post-op from hip surgery and you send a patient home, are they walking more or are they walking less? And that data could give a nudge to the orthopedic surgeon or the nurse, and that patient's not doing so great. Get them in, act proactively with small data. And where I think this is going to head in a meta sense is that we're just on the cusp of shifting between quantified self. A lot of us measure our own data. It's stuck on our smartphones, and shift that to quantified health, where it's going to play a role in optimizing health and wellness, risk stratification, doing early diagnosis, sometimes based on our digital exhaust, and then therapy. We can have much smarter feedback loops going forward. And we can measure all sorts of things now, not just your digital weight, but your digital shape. This is a startup called Shape Scale. So it measures your fat, muscle mass, other kind of fun ways that we can imagine having that as part of your medical record and data, a picture of your whole body every day or week. Simple data forms that we've had challenges measuring, hypertension, the number one cause of early death and morbidity around the planet, can now be measured on a connected watch, or several startups doing that with radar-based versions. BioBeats just got FDA clearance on a cuffless blood pressure monitor last fall. So we're going to start to get streaming real-time data, blood sugar, blood pressure, other elements. The challenge is, what do we do with that? The wearables are going, of course, beyond our feet to the idea of, insidables, chips underneath the skin, like Perfusa is doing to look at perfusion. So imagine our chronic disease patient literally can stream to us, complex data. It starts with the military world, but it's going to shift to chronic disease management. Or the idea of trainables. I don't think I have mine right here, but the idea that posture isn't great in our smartphone era. Now you can put a little sensor on your back, and it will track, are you hunched over or not over your laptop or your phone, and give you it can be your digital mother, and give you a little buzz in your back if you have been hunched over. About a week of wearing this, an hour a day, research your physiology. So example of not just measurement, but feedback. And shockables, hearables, ringables, all these new ways you can measure, just from the technology in your ear, it can start to pick up heart rate. Maybe as shown at CES, calculate blood pressure. Breathables, new forms of being able to impact early screening for diseases like lung cancer. Ingestibles, things we're going to swallow, and we'll look at the health of our gut. Sockables for diabetic patients and picking up early signs of a diabetic ulcer, for example, or a hot spot that they might not be able to feel. My favorite example of data and incentives aligning would be underwearables. I won't show you the one I'm wearing, but I got a pack of 10 of these from Spire. They measure heart rate, motion, respiratory rate, steps. And what's interesting, they started a few years ago as a kind of health company, tracking your breath, helping you with meditation, mindfulness, stress. And because the incentives changed last year with these new CPT codes for remote patient monitoring, now they can have an RPM platform and use this as a medical device to track folks with COPD, bronchitis, et cetera, and pick up a problem early before they need to come into the ER and need to be intubated, et cetera. So a smart, simple example of sensors. You get a pack of 10 of these. They're so cheap now, Internet of Medical things. You can have them on 10 pairs of your underwear. They can go in the laundry. They last a year. Simplification of the data flows as well. Another fun one, I was in Korea. I got the Welt, which is a smart belt that can track your steps and how much food you ate, really, but also risk for fall. So there'll be, maybe for folks that are at high risk of fall, we'll have an airbag on your belt. So fun other versions of this. Other things to quantify in the data era are food, measure input. You can even now, just got this, it's a device that tracks your breath, your metabolism. If I'm trying to be ketogenic, and tell me if I'm ketogenic or not. So you can measure that form of input. We can measure, there's a picture of it. Now output, so now we'll have new forms of data about individualized metabolism. Food is medicine. It's not one size fits all. So we're moving to this era of precision nutrition, measuring microbiome, genome, et cetera, and real-time blood sugar in some folks to really optimize diets. Now, all this data is great, but no one wants to charge their wearable and have it plugged in. I think we're entering this era of invisibles. The idea now that we can pull in vital signs from just your camera using AI machine learning. Here's another platform that's doing that. They can pick up off your smartphone and calculate blood pressure. I don't think they're FDA cleared yet, but that'll get there. So seamless ways of picking up vitals. New ways of using cameras to tell, let's say, aging in place, to pick up data. Is that older couple upright? Are they drinking? Are they dressed? Are they having breakfast? And it's a bit Big Brother, but we can use that to keep eye on folks who need it. Wi-Fi has been modified by MIT engineers to pick up the vital signs of 10 or more people living in the same room. So we'll start to pick up interesting behavior patterns and hopefully be proactive before grandma has to fall by looking at her data. And so this sort of whole ambient environment is going to get very, very interesting and creates massive amounts of data in our homes and elsewhere that we'll use to look at everything from mental health to cardiac health and beyond, hopefully nudge us in smart directions. So what are the implications when we're always online with our digital exhaust? Who owns that data? I've been discussed today, I think. How do we reward people for sharing it? How do we leverage incentives? You know, as is already happening, John Hancock will give you a lower life insurance rate if you're walking 10,000 steps. So people will hack this. People pay me to put steps in their Fitbits. Bit of a joke, but how do we leverage this big data as it's a new oil smartly? How do we align the incentives of clinicians? You know, this is a cartoon made in exponential medicine. What is it, doc? Just as I thought, you're generating too much data. I mean, because no clinician wants the data. We want that integrated into our workflow. And as many of us know, there's already burnout from having to feed the data machine that doesn't really actually improve clinical care or outcomes. So that kind of famous now, you know, fourth quadruple aim to improve clinical experience. We're starting to see these dots connect. HealthKit can now take our data, and I could turn the options and share it with my doc at Stanford. Actually, the day after I did that, Dr. Sharp is the CMIO at Stanford. Many of you know, wrote me a little note in my app, like, "Hey, Daniel, I've got your steps, heart rate, and weight data. Looks good. Thanks for submitting. Did you have your blood pressure data?" I'm like, Dr. Sharp's looking at my data. Wow, what is he going to do with that? What would he do with my Fitbit data if he had all that information? And it's nice to have it, but the challenge is no one's going to log in and look at every step. Or we need to synthesize that, right? And Project Baseline that Verily is doing, trying to understand in context all this digital health cost, along with medical records, is getting interesting. I'm not sure if it's been discussed, but the All of Us trial, kind of a Framingham on steroids for 1 million Americans. I signed up, I gave my blood, connected my medical records. All that will hopefully really give us this new lens on data to information to actionability and narrow that gap. And I think you're into an era where it's sort of synthesized. You know, there's no way we can make sense of all these data streams. Just like we have for our, you know, financial health, what if we had a FICO score for our wellness, or those for our patients, and synthesizing all these new data streams give us a hopefully AI generated check engine light that is most attuned to that individual. So building that sort of OnStar for the body for our patients will be critical. We're seeing examples of these sort of early check engine lights. The Fitbit now, or sorry, the Apple Watch can now call 911 if you have a fall and don't get back up. In the era of COVID and other infections, can our wearables and big data start to pick up signs of the flu? And I would argue that they can. When I got sick about a month ago, I watched on my left, I could see my resting heart rate went up for a couple of days. There's an app called Auto Heart, and it gives you all sorts of data about your heart. What if we could start to glean really new, interesting elements from that information early and do trend spotting just from our simple wearables? And now, of course, in the era of COVID, you know, how do we leverage all that data and give us, you know, personal check engine lights about your exact neighborhood or next block? And of course, so important now, I think, to sort of slow measure social distancing, et cetera. How do you know when and where to do that based on your locality and what's going on around you? So I think there's a real opportunity now to understand that on the exponential. Social distancing a day or two earlier make a huge difference. I was recently, you know, looking at other examples of the sick weather as a way of crowdsourcing, you know, who's sick with sniffles and the basic flu. But how can we put all that together in conversation with some leaders from the WHO? I kind of posed, could we kind of create similar elements, pulling these technologies together to almost build a crowdsourced map or ways for COVID? Because there's lots of information in our social graphs. It may be the reality, it's going to give you warning if you're around someone who's positive or looks like they might be positive for COVID or other diseases. So could we kind of create a ways for COVID in a sense that would be an integration that could be nationally distributed and help people have what they need in their hands that was just in time and personalized? Prior panelists are talking about cough. There are apps that can listen to cough. Maybe there's an AI algorithm that can pick up a corona cough versus others. The folks over Cloud Medics have now made basically integrated that into their chatbots, and several of the chatbots and AI diagnostic platforms are trying to integrate that. So I think a lot of interesting opportunities there to build these technologies together. Another company, Elemento Health, out of San Francisco, putting together platforms to help frontline teams have the right just-in-time information going forward. So great. So I'll pan off of that piece. All this new data, how does it make us change anything? Behavior change is hard. We need coaching. Now the advent of digital coaches, AI coaches, all this hopefully can enable the individual, the patient, let's say, consumer, not to be overwhelmed with the data, but to put it in context and be incentivized to share it and leverage smart design thinking. So that's we're not presenting data the same way to a millennial who wants to Snapchat their doctor versus a baby boomer who wants it presented in a different form in larger font. So all the design thinking elements of how do we do precision digital health interventions and information data sharing. I'm running way low on time. I'm going to skip ahead a little bit here. I think all the things that are cool things are happening with virtual reality, augmented reality, new ways of sharing information. I think a fun element with AR and VR is it's going to change how we learn, how we simulate, how we train. This is also VR. You can go into a virtual operating room, and in this case, train for surgery if you're an orthopedic surgeon or even not. So new ways of blending data information in real time, things like HoloLens, augmented reality, VR, is going to really shift medical education and hopefully, again, provide the right data information when we need it. And I like to synthesize that as this idea of a bit of a Waze for clinicians. It's going to, just like when we drive with Waze, looks at the traffic, we're all crowdsourcing that data. We're seeing companies start to do this. Theater is a company looking at and synthesizing videos from surgeries to learn and maybe give warning and guidance as future surgeons go through some of the procedures. So just like we have driver assist, we're going to start to have medical assist. Just like we have some robots that can do certain things together, we're going to start to synthesize those tools together. The future is sort of going to be one of guided care kind of together. Last 2 minutes, I'm going to finish up diagnostics. Tons are happening in diagnostics. All the imaging things I think you're all aware of. Great, massive amounts of new data. And the scanners are getting smaller. The ability to maybe have a scanner at your CVS, it'll do a whole body scan in 10 minutes, might be here in a decade. So how do we architect our systems today to start to store that information, make it accessible and useful? How do we think about new forms of where and how we collect data from our digital doctor's bag, whether it's AI or sort of telehealth, guided with diagnostics on site, the idea of, medical tricorders that can be in our pockets and hold down multiple elements of information. How do we take, a stethoscope now and upskill a nurse in a rural village, like the echo stethoscope can do an EKG and listen to heart sounds, and upskill who can be doing cardiac screening. All these examples are here now. Butterflies, ultrasound will get rid of stethoscopes, I think, overall altogether. And again, can democratize how and where we get things done. So lots of new opportunity there in the mobile space, all the way to the point of the laboratory is moving to the laboratory on a chip. Somewhere I have here my little smartphone laboratory element. You plug this little puppy into your smartphone and you can run labs, or it's JanaCare. Or we're going to move to the advent of the medical selfie. I'm on the board of this company, healthy.io, where you now use your exponentially better smartphone camera to take a picture of your urinalysis dipstick, and you've got the urinalysis done, sent to the pharmacist, to the physician, maybe even bypassing the doctor to get a treatment for UTI. So those are some of the things in the diagnostics piece. I'm going to finish and skip over, because I went way long on all the new forms of AI and hopefully synthesizing this together. I think, synthesizing the whole AI piece is the idea of the digital twin, individualized data, what you can look at for you or your patient. Mentioned just in the last section was the Green Button campaign by Nigam Shah at Stanford. So we'll almost have the ability to do that virtual, informatics consult and create that digital twin and really pick what drug really is going to match that patient's genome, microbiome, digitome, et cetera, going forward. And none of this, again, is going to mean that it's going to be human versus machine, not AI versus doctor or nurse. It's going to be, of course, the AI, the doctor using the AI replace those who don't. And in many cases, those who are upskilled using new data forms and AI can not necessarily replace the doctors, but enable the pharmacists and nurse practitioners, the PAs and techs to do things that normally required physician level training. So lots of promise there. Therapy, I think we don't really have time to go into in detail, but I'll just make the point that it was talked about earlier. All these new data forms, all these new apps, there's the need to sort of sort through them. You might prescribe an app for smoking cessation, for adherence, for tracking your heart, etc. Now, there's so much of this out there. I always get asked, what should I use if I'm a clinician or even a patient? So to kind of address that need, I've recently launched, still very alpha, a new website, digital.health. That's literally the domain. And the idea is to be a bit of a digital health formulary, hopefully with validated, FDA cleared and approved type devices. So if you have a cardiac patient, you can prescribe an AliveCor, or someone who's got depression. Maybe it's a mindfulness app. So a place to kind of pull those together. So if anyone out there wants to help on that, ping me. And we're putting together the team to kind of create, again, that useful digital health formulary going forward. And finally, how do we pull all this together to do the last mile of healthcare? All these new data forms, doesn't matter if you still have a pile of pills that no one's taking. How do we sort of synthesize our genomics, our microbiome, our digitome, and help pick the right drugs and doses so that they're really useful for that individual and not just based on randomized clinical trials for the average patient? So I've been thinking about that problem for a while, having trained in internal medicine and pediatrics. How do we start to integrate our meds to match the individual? A poly pill can be used for prevention, but what if you could build a personalized, poly pill that was built for you, based on you, adapted to you, that would have your, let's say, common generics in there, your 3 blood pressure meds, a statin, a beta blocker, an aspirin, or your vitamins. And so we built a platform to sort of take individualized data and sort of synthesize a personalized poly pill. So here's the printer, so that you can eventually print, modify, print. And that's a new platform called IntelliMedicine. You can see my last TED Talk for a little more detail on that, or go to intellimedicine.com. All right, so to finish up, in our hopefully now more connected, data-driven world, we're able to think about doing clinical trials. That's already happening. Analytics, cloud-based, letting patients who never had access to trials, or clinicians who weren't plugged in, to find and match, and then blend, digital and physical trials moving forward. Lots of examples of that coming together. And so back to the sort of ways concept, I think the future of health and medicine is hopefully going to shift as we've shifted how we do our driving. 15 years ago, we still use paper maps. Now it's hard to imagine getting around without Google Maps or Waze. What if we were all sharing our data sources? Interoperability was really working. We could create these local and national and global healthcare maps to help an individual patient on their wellness journey, or to treat a disease, or to learn and cross-fertilize and share, to get us to our healthcare journeys in better ways. And so we all think about ourselves as not just organ donors and blood donors, but as data donors, and we're aligned and incentivized to do that. So hopefully, I think the future of health and medicine is bright if we can leverage these exponential technologies. If we realize that we're here in 2020, but the puck is moving quickly, we want to skate to where it's going to be. And if we don't just take linear steps, but think exponentially, and are really the ones, I think, now poised to really create the future of medicine that needs to be here for all of us. So thanks. Sorry for going over time. You can contact me there. If you want a copy of some of the slides, just text your email to that phone number, and they'll show up in your box. Thanks a lot.
Yeah, Daniel, we have some questions on YouTube. Do you have a few minutes?
Yeah, I'm sticking around, sure.
Okay,
Let me go back to.
thanks for going through this. I mean, this really gets our minds churning. So how do you think many of these technology advances, such as VR for surgeries, how long do you think those will actually take to become commonplace?
Well, I mean, VR for surgery. I mean, we already have companies that have built and are now distributing. That company, Oso VR, started by my friend Justin Barad, as an orthopedic surgeon, is now moved from sort of the startup phase to the point where they're working with, I don't know, several large orthopedic device companies, and they're able to show that the standard way an orthopedic surgeon will learn new procedures, you have to bring them all together. They go to a sheep lab. It's kind of kludgy, expensive. Now you can train someone on one headset. And I think their last study showed they had like 230% better retention and outcomes surgical wise from leveraging that. That's just the education side. I think it's gonna be a while before you just put on your VR headset and I'm at home and doing surgery, but already platforms like Intuitive Surgical enable surgeon basically to be in a VR environment next to the patient and operate on them. The future of that will be, again, not just seeing inside the body, but getting guidance, getting warning, giving that kind of GPS as we go. And eventually we'll see more and more autonomous surgeries done. In fact, we already have some autonomous surgeries. If you have your eye corrected with a LASIK, type surgery, the eye doc basically, lines it all up and hits the button, and the robot does the actual cutting.
Yeah, no, that's awesome. So, question from Ishan: what are some of the areas that people can work to make clinical trials exponentially faster, especially for new diseases like corona virus or COVID, and bring those vaccines to market more quickly?
We already see some good examples of digitally enabled trials. There's a company called Science 37, I think, is sort of leading the pack in doing that. And so we do need to think a bit differently. I mean, there's that stat about, it takes 10 years, $7 billion per drug, and still more than half of them fail. So how to think differently about doing trials. We're not going to be measuring just the same old endpoints that we used to. It might be a cancer drug. It might just measure shrinking of the tumor. Now we can measure quality of life, steps, other forms of measurement that might be more and more valuable. So your clinical endpoints can change using some of these new data and digital tools. But clearly, I think COVID is accelerating some of how hospitals innovate, how we can do things faster, better. A friend of mine, an Aspen Health fellow with his company Inovio, within like 3 hours of getting the sequence for the COVID virus out of China, had basically found what looks like to be a good vaccine and are entering trials on that pretty soon. So lots of ways to connect the dots between the problem, solution, and hopefully proving efficacy.
Awesome. And a question from Kyle. So how do you think that the present day EHRs will evolve in this era of interoperability, especially within the next 5 to 10 years?
Great. I mean, the EHRs, frankly, they pretty much suck. I always overuse the joke epic fail, because they're not really they're billing engines. They're not really optimized for care. I think hopefully where this ends is our electronic health records or health systems will be, when you are, if I'm your clinician and I'm seeing you in the clinic or the hospital, I'm going to have hopefully this amazing data element inside that's behind the curtains, but it's going to know your wearable data, what's changed in your sleep and your resting heart rate, et cetera. It'll know your genomics, so that when I'm trying to pick a statin to prescribe to you, it goes, hey, this patient's not going to do well on the standard Lipitor at 40 milligrams. They need simvastatin at 20 milligrams. And then, by the way, as we learn how you do on that, because I can send you home with a connected blood pressure cuff or look at your statin data, I'm going to share that data with others, kind of like the Teslas of today. They're kind of quasi self-driving, and if they learn that there's a curve that they need to slow down on, they'll update the maps not just for that Tesla but the others. And so that these AHRs are learning engines, and they're hopefully all connected between the Kaisers and Geisingers and NHSs of the world. So I think that's the big opportunity with interoperability and the right incentives.
Yep. Cool. And the last question that we have is from Eric. What do you think companies betting on the emerging future technologies that you've mentioned should do to build consumer trust, to allow privacy-friendly, data-driven, the privacy-friendly, data-driven future of medicine?
Yeah, it's a great question. I mean, some companies are associated with more trust than others. I mean, part of it is how you communicate. Some of this is complex, whether it's just your digital exhaust or your omics. Who owns that? Where does it reside? How do you make it? If you want to be a data donor, do you get rewarded? How do you have some level of understanding that's really truly de-anonymized? I think most folks, they don't care about sharing their digital exhaust unless it might be their lithium level or their HIV status. So I think it's somewhat generational. But yeah, trust is important, but also being able to show that they get something back to the sort of Google Maps or Waze model. When you're driving down the street now, you're sharing your speed and location. You can also tell where you've been. You're supposed to be at that motel at 2 a.m. That's pretty private data. But from that, we build these rich maps of the driving landscape that we all want to use, so we get something back for sharing. So that's part of the trust model. Nothing's ever going to be perfect. People are hacking credit cards. They can hack your genome or your digital exhaust. Doesn't mean we shouldn't be smart about using it. And technologies like blockchain and others can play a role in that. So I don't have the perfect example, but we have to move carefully and slow enough, but not being stuck in our horrible HIPAA world. That's an example of a regulatory process that might have been well-meaning, but it was pretty much before the digital age, and now is, I think, holding back the ability for folks to share as we might want to, and to connect the dots and speed up life-saving endeavors.
Cool. Well, thanks a lot, Daniel. Thanks for taking time out of your busy schedule to present to the group on, live on YouTube and all that. So we really appreciate it. And so that's about it. So
congrats on pulling this off. I mean, the idea that you could do this conference in a week and this may be the mode of the future is interesting, and it does enable new forms of collaboration and sharing that can hopefully continue when we can still go back to regular life across healthcare.
Yeah, for sure. I mean, I think we'd all like to be in person, but unfortunately that didn't work out this year. But yes, this was a good stand-in, and we're glad to have you.
All right, thanks.
Thank you. So that's about it, guys. We're going to have the One Up Health team give a big shout out to all of our viewers. So you guys want to come over here for a sec?
Those of us left in the office, a lot of working from home today.
Most of the team is working from home. So thank you all for joining us on YouTube.
Thanks.
And thank you for all the speakers and the exhibitors. Everyone came together in very short order, like literally like 4 or 5 days. So thanks for that.
Thanks for
Thank
joining.
you.
All right. Bye.
See you guys.